flow, it should progress the way the way narrowing progresses in other parts of the body.
Is that time in the other parts of the body, is that months, years, or is there any time frame that's been determined?
No, there isn't. No.
My second question is for people who've had restenosis and those who have not, changes in exercise, diet, or is there certain patterns that you've seen in the people that are not having a restenosis?
No.
In other words, improving the success of the procedure?
No, we haven't seen patients somehow avoid the risk altogether of restenosis. It's the response that veins take. But I will say this, patients who smoke restenose much more quickly than patients who don't smoke. So that's the one pattern that we have found, and that sort of agrees with what we've seen in other parts of the body. Restenosis is much more rapid in patients who are smokers. So having said that, I'm sure that we will find other dietary and fluid-based things that we can do to decrease the rate. But I think it's more going to be the technique, how we find a way to manage the area of narrowing initially that keeps it from narrowing too much.
I've got two questions as well. In the four modes of blockage that you were talking about, the progression, does it, while it can increase and get to a complete blockage, can it go up and come back down? Can you basically be a 1 and go to a 2 and then come back to a 1? Does the body change like that over time?
I would never say never because, that's not the way the human body works, but I've never seen someone go from, in any part of the body, go from a level of without treatment, go from one level of narrowing to a lesser area of narrowing without treatment. I've never seen it. I haven't seen everything, and I'm sure that anything's possible. But,
yeah, my brain is kind of looking at the relapsing remitting concepts, and if you were to go from a 1 to a 2 and back to a 1, you might see improvements in your symptoms.
Yeah, yeah. Or, I think what we see in other parts of the body is patients have, I'll use as an example, mesenteric ischemia, which is a fancy word for it's arterial now. Bear this in mind. I'm not talking about veins. I'm back to talking about arteries. But in the mesenteric ischemia is decreased oxygenation of the gut, of the intestines, because the blood vessels to the gut are narrowed, usually by atherosclerotic plaque, by hardening of the arteries, okay? What we have seen in patients like that is they'll compensate. They'll have one of their major arteries blocked, and then they'll have a detour pathway that's open that's allowing them to feed that part of their gut successfully so that they don't get symptoms. And all of a sudden, they'll start having symptoms again. Their symptoms will get worse. And we'll look, and we'll find that one of the detour pathways has a little clot in it that's caused them to get worse. Those kind of patients can go from worse depending on what that clot does. If the clot dissolves, the body has ways of getting rid of these clots, and often it will. If the blood clot goes away, if your body's, what's called thrombolysis, if the body's natural systems for getting rid of clots work and the clot dissolves, you'll have a patient who has symptoms of abdominal pain related to their mesenteric ischemia, and then their symptoms will get better, and then their symptoms will get worse. And it's because, as you described, the channels that were allowing flow have changed on their own for better and for worse. Now, in the venous system, you could imagine what might happen is in a patient who has, let's say, a grade 3 or a grade 4 narrowing, they have collateral veins that are allowing the outflow from the nervous system. If a clot forms in one of those collateral veins, you would expect that patient to get worse. One of their detour pathways has gone away. The body has ways to get rid of those clots, and if they're successful at getting rid of the clots, you would also expect that that patient's now going to get better. But, I'm using words like expect and you would a lot, and that's not, it's okay for us here, but it's not applicable in a lot of scientific discussion.
The second thing that I'd like to ask about is that, in the video and such, it takes us to the point of you're now in the recovery room. And the question I've got is, having gone through this, I'm seeing, literature on the internet, et cetera, that says everything from outpatient day surgery to we want you to stick around for 10 days, okay? And it becomes sort of this question of...
You have to wait for the sequel video.
Is there some sort of a guideline as to how long you should stay close?
What I would tell you is this. We do venous angioplasty, venous stent placement, venous thrombolysis for a lot of reasons, not just for CCSVI. And we do a large number of these procedures as outpatient procedures, day procedures. Even the ones we do in the hospital, we frequently have patients go home the same day or the next morning. Having said that, whenever you do an intervention, you would really like to know that the patient is 24 to 48 hours out of the intervention before you get them to a point where you can't call them back in to just take a look at them if you need to. I think 24 to 48 hours for this procedure is adequate so that patients are recovered enough. You can bring them back in if you need to look at their groin. That's the most common thing that we get asked about, frankly. The two things that we see patients back for are bruising in their groin or they're feeling lightheaded. And usually the reason why they're feeling lightheaded, we get them back into the site and we find out that they just haven't drunk any fluid at all from the time when we did the procedure. And we give them a bag of IV fluid and then they drive back home and they feel great. So not being able to do that, I think, would be a disservice to us as well as to them, because we'd say, well, I'm pretty sure I know what it is, but you're just going to have to look for somebody up there to help you out. If you give it 24 to 48 hours, I think you're okay. 10 days, I got to tell you, I find that to be a little bit, yeah. There's other reasons to go to Costa Rica for 10 days. Yeah, that might not be one of them, but.
I have just one interruption. I want to say everyone will have noticed yellow papers because I see everyone writing on them. I would appreciate greatly if you would be able to just complete on the bottom. How did you hear about this presentation? Internet, CCSVI Foundation, friend, or advertisement? You can leave it on your chair when you leave, or you can drop it in one of the bowls or whatever, but I really would appreciate if you filled that out. And also, remember, there's still cookies, coffee, tea. We have water, and then up at the front of the room, we have some favors for people they'd like to take with them, and all of the items used in the procedure are on that end table on the right. If anyone wants to see what they look like, pick them up, ask questions, please feel free to do so. Okay, next question.
Just had a couple of short questions. When the procedure is performed, do you also, for any situation, have treated the renal or the iliac vein? I've kind of seen some literature on that. Maybe.
I have treated the renal vein in situations where there are indications that the renal vein narrowing are causing symptoms.
Okay.
Those have not been patients with CCSVI. Those have been patients who have what's called hematuria, which renal vein narrowing can cause, or patients who have pelvic pain, which renal vein narrowing can cause because the blood flow backs up through the veins that are supposed to drain to the renal vein. I think that though there is the possibility that renal vein narrowing could decrease the outflow from the azygous system to some degree, theoretically, I mean, they all connect. It's almost the same as me saying that, you know, internal iliac vein narrowing can cause the same problem. If a person doesn't manifest the symptoms that that vein narrowing should cause, in addition to CCSVI, it's unlikely that that vein narrowing is causing some other problem, if you understand what I'm saying.
Is that something you will see during the procedure itself? Do you cross? Like,
no, I wouldn't see it unless I looked.
I
wouldn't see it unless I looked. Could I look? Yes, it's in this. It's actually easier to look at that vein than the veins that we tend to look at. But unless you specifically looked at that vein, you wouldn't see an abnormality.
Okay. Just had a couple short other ones.
Sure.
Since the initial sort of screening Doppler has generated a lot of sort of false negatives.
Yep.
And you still may proceed with the procedure anyway and then find out. I've seen some literature that's saying, you know, there's updated protocols where they're moving away from this initial.
Patients, you know, a lot of it depends on timing. Sometimes patients say, you know, I can't get there early enough to get the ultrasound done, but I want the venogram. The only risk of that is that you do a venogram and you don't find an abnormality. And I would say that I believe in a lot of the early work that showed that the rate of CCSVI in patients with MS is very, very high. I think it's in the neighborhood of at least 60 to 70% in most studies, and in our institution, it's been higher than that. So.
Have you not had 3 and 500 that did not show blockage? That's all.
Yeah, we've had a very, very small number. It's probably more than 3, but it's low. It's very low.
The other question I had is you made a note that you won't treat patients that have a systemic infection.
Yeah.
Now, if they have a managed, localized chronic infection that's localized.
Yes,
and
like sinusitis.
Right, or being treated with antibiotics. Is that something you will still go ahead and...
Yeah, I'm talking about patients who have a question of, let's say, you know, have fevers, ongoing fevers of an unknown origin, or unfortunately we've had patients who have, decubitus ulcers are not uncommon in patients who are immobilized.
Right, that's what I was referring to.
And so if someone presents with a decubitus ulcer and fevers, and I don't know that they're not bacteremic, there is the possibility that I'm going to leave a foreign body behind here, number one, and there's a good possibility that I'm going to be in the bloodstream for a period of time, number two. And so what I can't do is take the risk that a day later this patient's now what we call septic. In other words, they can't maintain their blood pressure because their infection's so bad, and I don't know that it was the decubitus ulcer versus something I put into the person's bloodstream. So in that situation, we need to get the infection under control before we go ahead with our treatment. And that's what we've done, actually, with a patient right down.
Last question. the anticoagulants, typically how long do you find?
If I do an angioplasty alone,
Yeah.
no
Angioplasty
complications, angioplasty alone, 10 days, and it's Pradaxa now. We like to use the oral, an oral anticoagulant. You take 1 dose a day, usually around 100 to 150 milligrams, no lab studies. I think it's a great drug. There's another very good drug that not a lot of people are using yet, but I think is going to get used more, called Xarelto, that works in a similar fashion. You also take once a day and don't need to take any labs.
And also 10-day treatment?
And also 10 days. If a patient has a stent, it's a little different story. I may anticoagulate that person long term, if not indefinitely. So in other parts of the body, when I stent the iliac vein, if I stent the iliac vein, I anticoagulate those patients for lifelong.
For longer. Now, it's an oral drug.
Correct.
If someone is on a feeding tube, for example, can it be administered through a...
I don't know the answer to that.
You don't know the answer.
You know, we could always go back to the injectable form for patients who don't have the ability to take drugs by mouth. We could use Lovenox. It's just subcutaneous injection similar to Copaxone.
Okay.
So we have done that. As a matter of fact, we used Lovenox for a long time before Pradaxa became available. So.
That's for circulation, isn't it? Is it?
The Lovenox?
Yes.
Both of those drugs do the same thing. They're anticoagulants.
Okay.
They stop you from being able to form blood clots.
Right. Exactly. Okay.
Yep.
It's used a lot here as well.
Yeah, I'm sure. Yeah.
Okay. Now, in terms of last question, in terms of stent use, is there a max that, I mean, there's so many other studies being done, but if they find many areas, would they do a maximum of 3 stents at one particular time, or it all depends on who's performing the procedure?
I think your goal in most cases, I mean, we're talking about an area of anatomy that's only about 10 to 15 centimeters. I mean, it's not a very large area of anatomy. And frankly, I think in most situations, we should be trying to get, if we have to use a stent, we should be trying to use 1 stent because we have stents that are the size that would cover the whole area. Anytime you start overlapping stents, you have an increased risk of thrombus formation, increased risk of scar formation. I do have one patient who we've placed 6 stents in her jugular vein. Unfortunately, she came to us with stents that had been placed elsewhere. So we started off from a position where we just had no option. She eventually thrombosed her jugular vein. So, you know, I think the goal is to use as little metal as possible.
I was just wondering what the general consensus is in the CCSVI community. Do you guys consider this a cure or more of a preventative method?
I think we should consider it personally, I think we should consider, this is my own opinion, I think we should consider it a palliative or preventative method. I don't think we should consider it a cure because we don't know enough about it to say that it stops the progression altogether, number one, or that it goes back and stops what has already occurred. So I don't think calling it a cure is fair. Having said that, there are other procedures that we do in interventional radiology that I also personally will not call a cure, particularly things that we use to treat cancer in the liver, that comes very, very close on a scientific basis to approaching the results you can get from cure. The problem is until there's data out there to tell me that that is as good as surgery, I can't call that a cure either. So, you know, I may be too cautious here, but I think that, you know, it's better to be cautious than to be overzealous.